Good morning, everybody. I wanted to start by emphasizing the importance of understanding edema to our practice. Why do we need to know different causes of leg swelling? Isn't that what the ultrasound's for? If the scan is positive, then it's venous edema. And if it's negative, we can send them back to the primary care doctor, correct? Well, I wish it was, that clear cut. First, only about a third of patients with sonographic reflux are going to develop swelling. Second, patients dedicate their time, they adjust their schedule, they're investing copays for our consultations. So we should provide some value to their appointment, regardless if they're positive for venous disease or not. And then lastly, winning our referral base largely depends on how valuable of a resource we are when it comes to evaluating their patients. I often tell my clinical staff that we see patients for three reasons: either leg swelling, leg discomfort, or something visual that's affecting their legs. Obviously, there's some overlap, but we should be experts at evaluating leg swelling, leg discomfort, and visual abnormalities of the legs. This way, all patients can leave with a differential that is satisfactory, not only to the patient, but also the referring providers. We also need to know this information so we don't miss serious medical conditions, and so we can also best manage patients' expectations. For most people, lower extremity edema is not life or limb threatening in itself, but rare cases, it can be a clinical sign of serious medical conditions, such as like a DVT, cellulitis. It could also be the first clinical signs of systemic disease, such as CHF or renal failure. And also, it could be caused by some venous outflow obstruction from a pelvic or abdominal malignancy. So we should be really carefully evaluating these patients. But luckily, more common causes of lower extremity edema are not lethal. So I tell my patients no one dies of a swollen leg, but leg swelling can affect how our footwear fits. It affects our mobility and stability, and ultimately affects the health and the integrity of the skin. We see all day skin infections, skin rashes, skin discoloration, and even skin ulcerations as a result of chronic leg edema. Also, if the skin is injured, it can cause delayed wound healing, and this could also lead to infections. So leg edema can also affect the appearance of the legs, which may influence how people dress or how comfortable they are participating in certain social situations. So leg edema is a quality of life issue, and it can lead to other medical issues. I'm going to scroll through here real quick. All right, so leg edema can affect our patients in many ways, and it can develop in many ways. So I wanted to start by just listing some salient points that we all need to know. The most common cause of leg edema in older adults is chronic venous insufficiency. The most common cause of leg edema in women that are menstruating is idiopathic edema. One that I think oftentimes we forget, I call it the under the radar cause of leg edema, is pulmonary hypertension, usually from obstructive sleep apnea. And then we have to keep in mind that leg edema can develop from causes that do not include underlying disease like muscle injury, prolonged standing, excessive salt intake. And concerning causes of leg edema, we always have to think in an older individual, is this representing some systemic disease, DVT, infection, and malignancy. And, no matter, who you're evaluating, you always have to think multifactorial and also consider medication side effects. I think we've all seen the patient that came in and said, oh, my leg swelling just started, overnight. Started, in 2 days. Well, for us to clinically see swelling in the leg, you have to accumulate at least 2.5 to 3 liters of fluid in the interstitial space. So people that say their swelling just started overnight, they probably had a low level of swelling and it just reached that threshold to now we can clinically appreciate the swelling. I also, tell my patients that when we're 10 years old and our leg swells, it's one thing. When we're older than 10 and our leg swells, it's usually a combination of things. So, think multifactorial causes of leg swelling. Now, if you were to look up edema in medical textbooks, edema is typically classified into three types: venous edema, lymphedema, and lipedema. This classification was based on the classic Starling principles that is now being restructured. So the classic Starling model proposed that fluid flow in and out of the capillaries was determined by opposing hydrostatic and oncotic pressures. The flow rate was governed by permeability of the capillary wall. So under this model, there was fluid outflow along the arterial end of the capillary bed and reabsorption of fluid from the venous end. It was thought that only about 10 to 20% of tissue fluid was then drained through the lymphatic system. So Starling described this classical version in 1896, and it's been widely accepted for over 100 years. However, in the past 20 years, it's been revised. So a little bit of history, so bear with me. The endothelial glycocalyx layer was first kind of proposed in 1940. And it was thought to be a hydrogel-like layer attached to the endothelial cell lining of the capillary. And then about 25 years later, in the 1960s, it was first visualized via electron microscopy. The endothelial glycocalyx layer has two parts. It has a gel-like base coating the vascular endothelial cells, and it also has a second part, which is a hair-like structure that projects into the vessel lumen. It's influenced by intravascular forces, and channels within the glycocalyx layer controls fluid and protein movement. It wasn't until 2010, actually, so about 13 years ago, a group, Levick and Michael, demonstrated there's only net filtration across the blood capillary beds and no net reabsorption. So all capillary filtrate and tissue macromolecules were taken up by the lymphatic system. Thus, edema arises when capillary filtration exceeds lymphatic drainage. Also, if there's lymph drainage that's reduced, or if the lymph system is damaged and capillary filtration is normal, edema can result. So edema will form anytime the capillary filtration exceeds the maximum capacity of lymphatic drainage. In 2014, Mortimer and Roxon declared that the presence of chronic edema was synonymous with the presence of lymphedema. And then a few years ago, Bork and Hetrick, that's not the 90s pop star, but they explained all edema is in a lymphedema continuum. So these discoveries have challenged our historic way of classifying edema. Recently, it's been shown that heme-containing protein suppresses lymphatic pumping of the lymph, and this contributes to edema formation of venous origin. Also, lymphatic anatomy and contractility starts to degrade with the progression of venous insufficiency. This is where we see the phlebolymphodema. I'll also just briefly say that lipedema is kind of a misnomer because it's more maldistribution of fatty tissue. However, lipedema may actually stem from defects in the lymphatic system. Newer evidence is suggesting that the lymphatic defects prevent the ability of subcutaneous fat to clear fluids from its tissue and causes fat to be inflamed and swollen. So should we just be classifying edema in two ways, acute or chronic? And the lines between primary and secondary lymphedema are really becoming blurry. So newer evidence is pointing to two types of edema, acute and chronic, acute being less than 3 months and chronic being greater than 3 months. It's often multifactorial, and all forms of edema have a lymphatic component. Edema from CHF or an ankle injury produces an increase in lymph load that overwhelms the lymphatic system. And certain conditions like venous insufficiency, bacterial infections, or trauma, surgery can permanently impair the lymphatic system. So these are some ingredients to prevent edema. It starts with a good venous system, normal cardiac function, a healthy capillary endothelial glycocalyx like we spoke about, and an intact calf muscle pump, but it largely relies on lymphatic assistance. So we all know that there's two systems of veins in our legs, two main systems, the deep veins, which lie in the muscle layer, and then the superficial veins that lie above the muscle and below the skin. The deep veins in the legs are responsible for about 95% of blood flow up out of the legs. And when we do calf muscle contraction, it squeezes these deep veins, blood gets pushed up, the deep vein valves close, and then the muscle relaxes, which causes a suction, and that superficial system is drained into the deep system. And this cycle kind of repeats itself. So anything that can affect this cycle, whether it's muscle contraction, whether it's valvular insufficiency, whether it's outflow obstruction, intrinsically or extrinsically, can result in edema. When I evaluate lower extremity edema, I think of four things. I think first, is it unilateral or bilateral? Is it acute or chronic? Is it painful or painless? And are there any associated systemic symptoms? So we're going to first talk about the list on the left. We're first going to talk about bilateral causes of lower extremity edema. We'll talk briefly about some common causes. We'll review some systemic causes, and then also look at a few medications that are usual suspects in contributing to lower extremity edema. And then we'll move on to unilateral causes of edema, common causes, and patients that we'll talk a little bit about patients that are presenting with unilateral leg edema that's usually more acute and painful. And then we'll talk about some conditions that can present either as bilateral or unilateral edema. So common causes of bilateral lower extremity edema. Of course, dependent edema. If we all sat and listened to these lectures all day and didn't move, we'd all probably have a low level of swelling. Would we accumulate 2.5 to 3 liters of fluid so it was clinically evident? Maybe not, but we have to worry about patients that are inactive, that are wheelchair bound. I think we've all seen patients that, we don't ask routinely, but they end up sleeping in like a recliner, and their legs are constantly fighting gravity and they get no reprieve. There's a premenstrual edema. So this is more of a cyclic type of edema that's associated with the menstrual cycle. Obviously, edema can start early on in pregnancy. And then idiopathic edema is the most common cause of edema in a menstruating female. It's a pathologic fluid retention in the legs while standing. And these patients can actually, if they weigh themselves in the morning versus the evening, they can retain up to 3 pounds of fluid a day. Usually these patients also have some fluid retention also in the hands and face. A lot of times in a younger female that has edema, I ask if their rings get tight, as well as is that an associated symptom that they experience with their lower extremity edema. Also, idiopathic edema is seen more in obese, depressed patients, and ironically, patients that have had a history of diuretic abuse. There's a test called the water load test. I don't know if all primary care physicians know of it or even perform it, but there is a way that this can be diagnosed. And treatment starts with spironolactone because most of these patients have a secondary aldosterone, have increases in aldosterone. Now, the last thing I will mention, patients with inferior vena cava filters, always think about thrombosis of these devices as well when you're evaluating patients with bilateral lower extremity edema. So a few systemic causes. So any older patient, in the textbooks, it tells us that if we have patients with bilateral lower extremity edema and they're over 45, we should be really screening this patient population for systemic causes of lower extremity edema. I think it's always good practice to screen all patients regardless of the age. We obviously don't want to miss things like heart failure. So asking them if they have dyspnea, orthopnea, PND. You may want to do we focus mostly our physical exam on the lower extremities, but, look for JVD or lung crackles. Obviously, a beta natriuretic peptide via serum testing and chest x-ray can help make this diagnosis. As I mentioned before, sleep apnea is a common cause of lower extremity edema. If patients come in with their significant other, you can ask if they wake them up all night from snoring. We see sleep apnea more in obese patients with large neck circumferences. I just was at Vision and I had to get a new dress shirt and my neck circumference went up half a size. So I think I'm approaching this 17 inches. I gotta work on that. Diagnosis is sleep studies and echocardiogram for pulmonary hypertension. Now, hepatic disease, usually the edema that results from hepatic disease is late in the course of the disease. You're not getting albumin produced. And this edema is not dependent. So the patients go to sleep with leg swelling and they wake up with leg swelling. Whereas a lot of these other systemic causes of edema, there is going to be a dependency to it. It's going to be not so prevalent in the morning and worse as the day goes on. Acute kidney disease, this is a tough one to diagnose because a lot of times other than the edema, there's not a lot of physical manifestations. Sometimes you can get some periorbital swelling in patients that are having kidney disease. And then, of course, thyroid disease, Graves' disease, which causes pretibial myxedema. I'll show a picture here in a second. You can appreciate the dry, thick, non-pitting edema that overlies the anterior aspect of the lower extremity. And you can see that picture to the upper left-hand corner. So a few physical signs to look for: pretibial mixed edema, JVD, spider angiomas, all represent more systemic diseases. So medication side effects, common medications that contribute to lower extremity edema. I think one of the big ones that I see a lot of times is the dihydropyridines, the amlodipine. And the amlodipine and nifedipine are more common to cause edema than the verapamils and diltiazems. We also know that about 5% of patients that are on NSAIDs will get edema associated with the NSAID. It's very popular these days for hormone replacement, and guys taking testosterone. A side effect is lower extremity edema, and we're often seeing patients with not only swelling in the leg but pain in the legs. And a lot of this pain can be neuropathic or representing a radiculopathy. So these patients are often on gabapentin and Lyrica. These two medications, there's about an 8% incidence of lower extremity edema with these medications. And then lastly, some of the new diabetic medications are also a common cause of lower extremity edema. So let's quickly talk about unilateral edema. In my experience, unilateral edema typically presents in a more acute fashion, although it can be chronic with lymphedema and venous insufficiency. It's usually also, in my experience, unless it's like a venous outflow obstruction, there's usually some pain associated with it. The good thing about unilateral leg swelling is you rarely need to look for systemic symptoms or systemic cause. It's usually going to be due to something in the leg or right above the leg. So that kind of helps you speed up the evaluation for sure. Things that we commonly see, DVTs, obviously. We've had a bunch of lectures on DVTs, so I don't think we need to go into that in detail. But just think, we worry about DVTs for three reasons. Obviously, the acute pain and swelling, and then the potential for a pulmonary embolism, but always consider post-embotic syndrome. So even if it's not an acute DVT, this is still something that we have to consider as a common cause of unilateral or bilateral lower extremity edema if they've had bilateral DVTs. Superficial venous thrombosis. Again, these when I was first training, SVTs were just treated with warm compresses, anti-inflammatories, and compression. We now know that some of these superficial venous thrombosis can propagate into the deeper system. So any superficial venous thrombosis that's greater than 5 centimeters in length or is close to a deeper structure, consider anticoagulation. Cellulitis, I think all of us have seen patients that are sent to us with red, swollen legs that are on antibiotics. I can't fault these doctors for seeing these patients in a small window of time and putting them on antibiotics, but after you've seen a lot of cellulitis versus venous stasis, dermatitis, or the rhubarb you get with lymphedema, you can kind of identify it pretty easily. And there's a good study a few years ago that showed that a third of patients that were admitted into the hospital with the primary diagnosis of cellulitis, a third of that diagnosis was wrong. It ended up either being a DVT, a venous stasis dermatitis, or some type of atopic dermatitis. So we'll see this very commonly. Painful causes of unilateral lower extremity edema, chronic regional pain syndrome or reflux sympathetic dystrophy. These are patients that come in with unilateral painful limbs. They have a history of trauma. So again, taking a history is very helpful. Ruptured Baker cysts. I think we've all had our sonotechs come and say that there's a lot of fluid in the calf. This typically represents either a hematoma or just fluid and blood from a ruptured Baker cyst. Also, other traumatic injuries like gastroc tears can present with unilateral acute painful edema. Usually a clue here is that they'll have some ecchymosis down around the ankle or foot due to the injury. And then neuropathy and foot drop. Again, we go back to it, deactivating the calf muscle pump, and this can result in chronic edema. And you can have associated radiculopathy with this. You can have see this in patients with strokes or with MS. And then a few common causes of either unilateral or bilateral lower extremity edema, lymphedema, lipedema, venous insufficiency, and also pelvic congestion or venous outflow obstruction. Won't go into that too much as we talk about that on a daily basis. So again, to kind of sum up what we talked about, the things on the list on the left, typically unilateral. It's very rare to have bilateral DVTs, but they do exist. SVT, cellulitis, ruptured Baker cyst, gastroc tear. All of these unilateral common causes of swelling is also associated with some degree of discomfort. Things that are more bilateral are your medication side effects, your dependent edema. In a younger female, there may be a combination of premenstrual edema as well as idiopathic edema. Systemic causes are going to present with bilateral lower extremity edema, and then we have ones that could present unilaterally or bilaterally. And then some rarer causes, but things that you don't want to miss. So especially with venous outflow obstruction. So again, history and physical become very important. Age of the patient, can rule things in and out for you. Duration, like we said, is it painful or painless? And systemic symptoms, all good things to ask the patient. And then if you want to take it a step further, we always want to know exacerbating or alleviating factors. Always every day my tech will come to, or my nurse will come to me and say, oh, the patient's positive. And I'll say, okay, what's going on? And they'll say, oh, they have, a refluxing trib in the calf. And I said, okay. And, you kind of want to know, does this discomfort get worse in the evening? Is it focal to that area? Is it better with stockings? It's important that we really try to vet all of our findings on sonogram to make sure that if we treat this this reflux segment, that it's going to actually benefit the patient. There's no guarantees, but there's things we can do to try to help increase the likelihood that what they're experiencing is due to the underlying reflux that we find on the ultrasound. Then physical exam, again, unilateral or bilateral. Is it generalized or focal? Is there foot involvement? Look for, again, systemic findings, just to make sure we're not going to miss cardiac, renal, or hepatic clues. Some skin clues, since we focus a lot of our exam to the lower extremities. Hyperkeratosis, we see it's that, brawny, warty skin with lymphedema. Are you seeing a lot of hemosiderin deposition? Think more venous insufficiency. Warm, sweaty, tender skin. Again, history of trauma. This could be early reflux sympathetic dystrophy. We all kind of have seen lipedema. It looks like lymphedema, but oftentimes the differentiating feature is it spares the swelling, spares the foot in lipedema. And if you do have swelling into the dorsum of the foot, we know that this may be more primarily lymphatic. And then, of course, warm red, tender, well demarcated skin can oftentimes be a cellulitis. I know we don't do much labs or imaging outside of the ultrasound, but I feel if we're, just so if you have access to labs and other sources of imaging, I just wanted to list them here. And then a few quick clinical recommendations. A lot of this is not based on good quality research. It's more consensus and usual practice. But an MRV of the lower extremity and pelvis should be obtained in patients with unilateral swelling, and a negative duplex ultrasound if there's a high suspicion for DVT. I think we can also use sonography to a certain degree for this as well. Echocardiography should be performed in patients with obesity, obstructive sleep apnea, and edema to evaluate for obstructive sleep apnea and pulmonary hypertension. ABIs should be measured in patients with chronic venous insufficiency and multiple cardiovascular risk factors before initiation of compression therapy. And for patients with chronic swelling, good skin care is a must. And pneumatic compression devices should be used in conjunction with treating some of the underlying issues in patients with lymphedema. And stockings should be used in patients following DVT to prevent post-thrombotic syndrome. I think there's some controversy whether this will prevent post-thrombotic syndrome or not, but I think the stockings are good to use to control some of the initial pain and swelling for these patients. So basic treatment for all patients with edema: compression, elevation, exercise to a certain degree, weight loss, monitor salt intake. Diuretics are rarely necessary. As I just mentioned, skincare is vital, and try to identify the underlying causes. If we do have heart failure or renal insufficiency, loop diuretics are the first drug of choice. You have liver failure with ascites, we add spironolactone. Also, as I mentioned before, spironolactone and also thiazides can be used for idiopathic edema. And rarely do we need diuretic use for lymphedema, chronic venous insufficiency, or So sorry, a little busy here, but again, just kind of walking through clinical decision-making, good history and physical, bring us down one or two of these pathways. Just again, I can't emphasize enough, bilateral lower extremity edema in an older individual, just take an extra couple minutes to ask for systemic symptoms, and just one or two other steps in the physical exam can really help these patients. So a few pearls: pelvic and rectal exams are low yield in patients with lower extremity edema, thank goodness. Abdominal and pelvic CT should be considered. Patients over 40 without an obvious cause of lower extremity edema. And also younger patients with unilateral edema, pelvic signs and symptoms, and weight loss. And then, you may, I think for most patients with lower extremity edema that are older, even if we have a clear-cut cause, we do want to get them back to their primary doctor so that they can get the appropriate workup to rule out any systemic issues. So to wrap things up, unilateral edema does not require an evaluation for systemic sources. Either think venous outflow obstruction or something going on inherently in the leg. Again, edema from liver disease or any state where there's decreased plasma oncotic pressure, it does not change with dependency. For all comers with edema, Doppler ultrasound is a perfect start. It evaluates them for the most common cause of lower extremity edema, which is chronic venous insufficiency, and it can detect some more concerning causes like DVT, SVT. You can even pick up some sometimes benign things like Baker cyst. And then again, the most likely cause of leg edema in an adult over the age of 50 is venous insufficiency. Venous insufficiency, we know, affects up to 30% of the population, maybe more, where heart failure only affects 1% of the population. But again, you have to do our due diligence when we're evaluating patients, and don't let that 1% pass us by. So I appreciate everyone getting up early and their attention on this Friday. If there's any questions or anything we can discuss, I'm happy to do so.
So thank you, Sean. So for the fellows, one of the reasons why I love this talk is because it emphasizes the fact that, we are venous and lymphatic medicine physicians. There's a very low doses that can cause a lot of the symptoms that we see that are not related to venous disease. And it's your responsibility to make sure that you're not treating a patient who has something else, and to communicate those findings to your referring physician. So, Sean, one of the questions I wanted to ask you was about pulsatile flow. I mean, our techs oftentimes come to us and say, I see pulsatile flow on the duplex ultrasound. Do you do anything about that when you see it?
So the one thing that I worry about with pulsatile flow in a patient that does not have like a heart history is like atrial fibrillation, congestive heart failure, things of that nature. So it definitely can be a good clue to screen these patients for systemic disease.
Yeah, so I think for the fellows, the data shows that in only about 25% of patients, when you see pulsatile flow, is something else going on. I think some of the clues or pearls that Sean gave, if you see somebody who's got pulsatile flow and they also have a history of obstructive sleep apnea, they may have an underlying pulmonary hypertension. Also, if you have access to an abdominal probe and the techs look at the inferior vena cava and it's 2.5 times the normal diameter, that's also a sign that there might be some venous hypertension. So I think as an overall general screening, it's not very sensitive, but if you associate it with other symptoms that the patient has, those are probably the patients that you should refer for further evaluation, especially if they're older patients, have a heart history, obstructive sleep apnea. Look for other clues that may be the cause of it. Most of the time it's a nothing burger, but if in that 25%, you may miss actually a real cause of it. So does anybody else have any questions for Sean? Let's see who's there. So for the fellows, I hope you paid attention to this, because one of the things I tell the fellows all the time is that we don't treat ultrasounds findings, we treat patients. So if your ultrasound findings, it doesn't correlate with what you're seeing in the patient, go back and take, examine and take a history. And more often than not, you'll figure out what's going on with the patient. All right. So if no other questions, everybody have a great weekend. Thank you, Sean. Once again, fantastic talk. Always appreciate it.
Thank you.
And
Appreciate it.
see you guys soon. Be well.